Good morning, the brave and few. We will see how long time my voice will last because I have a little bit of a throat infection. I will mention the keratitis problem during the course of my presentation since we have some new stuff for you. Now, with the permission of the chairlady, I would like to ask the audience a couple of questions. How many of you have had presbyopic refractive surgery? If you raise your hands, we can have a look-see. No hands raised. Very good. Now I pose the second question. How many of you have had refractive surgery done to your corneas? I see one. Two. I have two. Okay, great. How many of you have had refractive lens exchange? None. So out of this audience of about 30 people, there are 3 of us that know what we talk about and have gone through some of the problems that we are facing. Now, I'm going to show you a list of different procedures that we have performed during the years in corneal refractive surgery. You can read the list yourselves because I'm going to talk about something totally different. Now, we are facing a huge problem. As a scientist, as a researcher, I'm quite worried. And why is that? That is because our next generation of young ophthalmologists will face some of the problems that I will talk about later on. How do I fix this patient up? How do I arrange for the patient to have a decent living and working with their eyes? You have to remember that many of the procedures that I have listed are non-reversible. You cannot go back. Once done, it's done. And we have to figure out how to solve that. I'm going to show you some of the topographies that we have come up to and encountered and try to give you some solutions. There is, although, hope for the future with certain methods to improve the visual quality. When it comes to microbial keratitis that you're all interested in, I am happy to say that we are at the moment working in Israel on a slow release system which is very, very promising indeed, and it's non-invasive. That is to say that we can charge a plug, punctal plug, with whatever eye drop you would like to have and administer to the patient. You can charge this plug with up to 1,000 micrograms of any solution that you choose. The release system works like this, that we can release 2 micrograms per day or 4 micrograms per day. That is to say, you can have the plug in for about 500 days if needed. Of course, you can choose shorter periods as well. Now, coming to the problem. As you see on the screen, there are different topographies that don't look too good. And how on earth are we going to get these people to be able to recover their visual ability? Standard intraocular lenses and the formulas we use, keratometry, will certainly lead to refractive surprises. We are number one in underestimating the IOL power. We have an unexpected hyperopic shift after cataract surgery. And these refractive surprises seems to be directly related to the amount of keratectomy performed. And this means that greater refractive corrections correlate with greater errors of IOL power. Here, another example of a fairly bad outcome. The IOL power determination is dependent on axial length, corneal power, and anterior chamber depth. They are not independently measured. So an error in any of these parameters can lead to possible refractive surprises. It's a beautiful example of RK, and I like to show, particularly to show you picture D and picture E. Would you ever do it like that? How on earth are we going to get that patient to see? The RK flattens both the anterior and the posterior corneal surfaces, but only in a small central optical zone. And that is the one that we need to worry about. And the effect of the optical zone diameter is quite obvious. It overestimates the true corneal power because of the central flattening. And we will get a residual hyperopic shift that can persist for years. And therefore, in post-RK eyes, true corneal power can only be estimated by taking into account the small effective optical zone and post-op hyperopic shift. So we have some unwanted phenomena, and one of them being astigmatism. How about the lasers? Well, one basic difference between laser and RK is that here we only work on the front surface of the cornea. So we are modifying that. That helps a little bit, but when you do your calculations here, you need to measure both the anterior and posterior corneal curvature, and thus calculate the true corneal power. Do you realize that as of 2010, up to 2010, There have been no medical studies to determine the long-term effects of laser eye surgery. None. It's scary. FDA reports the possible risks, visual disturbances such as glare, halos, and or double vision, poor nighttime vision, and the development of severe dry eye syndrome. Whenever you hear a rep say to you, our laser, our method does not give dry eyes, it's not true. All procedures give a dry eye to a certain extent. So what are we doing with these patients? How can we correct them? We can do it the old-fashioned way, and we see a resurgence of the miniscleral rigid gas permeable lenses. They are excellent, but many of these patients just do not want to have that type of lens. It can be a little bit difficult to handle, but it does correct the vision. So what do? We have two options. And these options are to increase the depth of focus of that patient and to decrease the higher order aberrations. And we can do that quite easily with the new development of a drop, and here I have the financial interest a little bit, and that's called the Presby drop. It works extremely well in these cases, as one of our studies have shown. So there is still hope for these that have undergone all the procedures that were listed in the beginning. They are now getting either presbyopic or they are getting cataracts. And you will have some tools for that. Also, I will leave you with another thought, that microbial keratitis, we have a solution for that that looks indeed very promising. We've come very far on that. What I can give you the results on is on glaucoma treatment, where we lower the intraocular pressure by about 10 millimeters of mercury, and this has been done during a 6-month period. And we are currently doing clinical trials in Israel and elsewhere. With that, I leave you. I wish you a very nice day, and thank you very much for your kind attention.